right, our next speaker is Jamal McClendon, who will be speaking about the utility of technologies in the treatment of pediatric deformity.
Great. While this is loading, I want to thank everybody for having me. Thanks to the course directors as well, and thanks for all of you attending. Great. Thanks once again. Also, thanks for allowing me to get out of the heat of 115 in Phoenix. Welcome. Everyone sends their regards from Phoenix. So I'm going to speak a little bit about some of the newer technologies, and then also some of the incorporation of some of the older techniques that we have been used to allow for more sophisticated correction and deformity plane correction for the patients in the pediatric population, both the early onset and some of the later onset. In addition to talking about, even though we try to make strides in a lot of areas, some of the older, more technologies and things that we do still have a lot of relevance. And these are my disclosures. So last year I spent a little bit of time speaking about, and this is a little bit of piggybacking and overlapping on Dr. Javedan's discussion and talks regarding decision points regarding AIS and where we're going to stop proximal distal fusion levels. In addition to thinking about if the shoulders are high or if we're going to fuse the main thoracic, the proximal thoracic curve, or if there's any kyphosis, how we extend up proximally. And then furthermore, making decision points on how we stop distally, even though my personal bias is to stop at L3, quite frankly. So as we think about new technologies that we're incorporating into pediatric spinal deformity, we need to make sure that we have the idea and the understanding of the nomenclature, in addition to what conditions and syndromes do impact these spinal deformities. And so for our discussion today, we're going to review some of the newer technologies and how we actually place fixation, explore some of the methodologies for manipulation, discuss modalities for how we image the spine, and see if there's some new strategies in which how we can visualize and improve the safety of placing implants or getting the appropriate correction. Then also revisit and re-explore some of the older techniques. I love this. I love Dr. Lahner's last comment on the utilization of the anterior release, because this is a patient that came into our office. This is a patient that is a 12-year-old that kind of came down from near the Mexico border that was a little bit lost for a little while, but you can ultimately see had a pretty significant explosion of a 100-degree curve. Now, with the power of our implants, and without any posterior releases, you can take off a little bit of the inferior facet, and you can get pretty significant and quite robust improvement of their coronal plane alignment with relatively ease. But is there a way, even with the anterior release, that we could have allowed for some improvement, or even perhaps some halo tractioning in preparation? But it's hard to argue that this wasn't satisfactory. So I like to play this picture because this is a nice one, because when our patients send us these sort of videos at the 4-week follow-up period, it's hard to argue that trying to think of new techniques and new strategies, particularly for this Linky 1AN, for us to try to do something different and to increase their flexibility when they send you this cringing videos at the 4-week time period. So incorporating newer technologies and operating room efficiency, it's a balance. It's a thing in which we always consider in ourselves. And so when we think of having residents and fellows and teaching our residents and fellows and focusing on blood loss, at our institution, we like to use a two-surgeon technique, and really highlighting on some of the collaborations that we have with orthopedics and neurosurgery. We can do very efficient surgeries and also teach our residents and fellows in a very efficient time manner. But we try not to overthink things. A 22-year-old with an AIS, it may be relatively straightforward for us. So how do we decide if we're going to incorporate and potentially expose the patient to some radiation? Patients do ask us, how much are you going to radiate me in the operating room? Or if we decide to use some robotic techniques, particularly when we show some examples of very sophisticated improvements without using some of those modalities. And this is, again, highlighting how we can efficiently do surgeries and get significant correction without using those. So our focus today is on the deformity, particularly of all different kinds, adolescent neuromuscular, congenital, syndromic, revision, kyphosis, and what are some of the things that we can use. So in our practice, we use a lot of the freehand techniques. We have started to utilize the neuronavigation and the incorporation of intraoperative navigation, or maybe even modification with the CR for some of the more syndromic or smaller pedicles. Whether we're going to use robotics or a robotic arm, kind of depends a little bit on some of our personal strategies. Starting to incorporate augmented and mixed reality, I think, has some advantages, and I'll show a video of that. And then, do we have advantages of also using things in the biplane suite, or whether it's in the angio suite, where we can get really, really sophisticated, a large head, small radiation dose imaging for our patients that will allow for visualization, and it's a pretty unique and pretty cool technique. So for our infantile and our early onset deformity, we had a very nice talk on Wednesday, just really describing that, addressing these patients with the casting earlier on, we can really allow for a cure. And if we can really get them at 18 months, we really can significantly modulate their growth and guide their growth to a significant improvement where they may or may not necessarily need an intervention, particularly if we can address it very early on. And we also know the beneficial effects of bracing, and the literature out of Iowa for the patients who are at that 30 to 35 degree mark, where we can actually allow for an improvement or even the maintenance, where they may not necessarily need surgery. But really, for our early onset deformity, it's our focus is on guided growth, and if we can actually allow for an improvement of their pulmonary function, if we can get to a certain T1 to T12 height, that's ideal and maximal. That's really our focus. And are there some technologies that will allow us to do that? Very clearly, I've shown you video in examples of the instrumented fusions, but there are some growth-guided techniques that we have been utilizing and employing because of the desire to have an improved pulmonary function. We can do volumetric analysis and assessments to also show that the restrictive pathology and, quite frankly, some of the obstructive pathology can be changed by some of the growth-guided techniques. So our practice has started to incorporate some of the magnetically controlled growth rods in addition to using the traditional growing rods, though the complication rate may be a little bit higher for the traditional growth rods, and the overall survival of the magnetically controlled growth rods may be higher. We still try to utilize the increasing the prevalence of the magnetically controlled growth rods for these patients and this population. So this is an example of a patient that had a neuromuscular deformity that we followed as an infant, that developed a progressive kyphoscoliosis, and we can use the magnetically controlled growth rods harnessing to the ribs that then will allow for some growth guidance as this now 6-year-old will kind of continue on, and we will modify this in the operating in the office. That's a little bit different than a patient that we had here, where their apex of their deformity is a little bit higher, and it's hard to think of fixation in which we can get a little bit higher up there. This was initially a patient we saw when she was 3 years old, and we kind of followed her and closely utilized maybe a cervical collar to address the cervical deformity. You can clearly see that she has a fixed deformity in her cervical spine. We used some of the traditional growing rods and lengthened over time, and ultimately was able to get a slightly satisfactory, but it's a little bit hard to segment the cervical spine, particularly with the vertebral artery there. So we were able to kind of at least guide her until her 10-year birthday, and then did a definitive fusion. But that being said, there are some failures that we come across. And so as we're trying to incorporate newer technologies and trying to think of, for a 3-year-old who has, a pretty significant and robust deformity and started to develop symptoms of myelopathy, maybe a short segment fusion, and then, plus or minus, should we have done some growth modulation over time? Certainly that is an argument and something that we should have done. But we elected to do, a vertebral column resection at several levels and a short segment fusion. Unfortunately, with her skin prominence and with her being an active 3-year-old, she had some screw pullout. That screw pullout ultimately led to a wound challenge, so it needed to be revised. And so the new technology here is the incorporation of our plastic surgeons to help with closure of this one, in which we can get some very nice flap reconstruction for. So getting back to decision points and decision makings and on patients, and I always, for whatever reason, our patients love to send us these trampoline videos. This one is a little bit after 4 weeks, but I always wonder, us by stopping at L1 or L2, are we substantially limiting their flexibility and their range of motion? I know that Dr. Bourbon had mentioned the rower case of a Shorman's case, in which he was still able to row afterwards, but ended up stop rowing, not because of any loss in flexibility. But I always wonder, stopping at L1 or L2, are we changing any dynamics or course regarding their overall range of motion? Thankfully, Dr. Leonard had spoken quite extensively on the applications of anterior vertebral body tethering, in which we started to incorporate at our institution based on the patients desiring that particular modality. And we've had some successes, and we also had some failures as well. So this is a very nice young girl, a 12-year-old with Saunders 2, that came in to see us, and we kind of followed her in time and incorporated the technique and had a very nice result. And so we also go back and forth to ourselves, how we personally make decision points, particularly for the patient population that we have, really wanting their rib hump to go away and really wanting their crease in their lumbar spine to disappear. Is this a good strategy? And I would argue that yes, if we have a success versus when perhaps maybe we're getting very excited about the technique, and we may have not have selected the appropriate levels. We may not have had the appropriate tension onto the actual cord itself or onto the tether itself, and then we get a substandard or subsatisfactory result, and we say, maybe we need to not utilize this technology. But I would argue that perhaps maybe this is the time to go back into the lab and to reach out to Dr. Newton, Dr. Lahner, and the experts on how we can continue to help this population for those who have a need for an anterior tether, because I do think there's applications for it, particularly as discussed even in the lumbar spine. So we still have a lot of success and have a lot of benefit for the traditional techniques and the power of the implants and the power of using fixed screws, which we mostly use in our practice, and quite stiff rods. We can actually get pretty nice correction. The augmented reality is something that we've now incorporated. So instead of using a two-dimensional platform, using a three-dimensional platform and having holographic representation in which you can actually move and manipulate and overlay it on top of the patient, is one of the newer technologies in which we started to explore. So I'm just going to play these kind of short videos, and I hope they're not too loud. Let me try to turn it down here. So you can actually get, in your view, you can put on essentially a platform glasses in some way, proprietary glasses, and you can use hand manipulations to rotate the actual spine in front of you. And then you can actually overlay it over the patient. You can increase the size, you can increase the nature of it, you can kind of match it. It's not a perfect thing, but you can also go in and out of the actual representation and make decisions. This is a little bit of another video in which I just leave it in front of me here, and then I just look at how the pedicle cannulation can be. But it's just another representation. So I know some individuals have utilized an actual model and put that model into plastic. I like this because you don't necessarily have to put that model in plastic. You can have it kind of in front of you, and you can still work and work directly as you essentially have that representation in front of you. So I like it in that regard as well. So this is some of the things that we're starting to figure out, different workflows or how we can actually improve the software technology so that it can be a little bit mirror or perhaps even use navigation in regards to it. So we started to have the fellows wear it in addition to myself or some of the other partners. You can actually do some preoperative evaluation right before while the patient's in the operating room, just to make sure that everything lines up appropriately. And then one of the videos I mentioned, or one of the techniques I'm started to use last time. So, some of the newer opportunities are to use the Dr. Skaggs technique of placing implants, where basically you just take the high-speed burr on type C and type D pedicles, type A and type B pedicles, in which you can just cannulate directly into the cancellous portion and get into the body without impacting your rotator cuff. And I won't belabor that. Or do we now start to use some of the biplane suite and biplane technology, where we have the patient literally on the angio table and we're doing these scoliosis corrections, and then we can get three-dimensional representation, a pretty cool imaging after we capture that, just to make sure that our implants are satisfactory and are okay. And we can get three-dimensional rotations just to look at our implants, which are pretty nice, just to make sure that there's a safety component and safety element there. But finally, I'll just touch on the idea and the very important concept of cord relaxation. It's not to be understated, because really, even though there's a lot of techniques in which we can utilize for patient safety, the thing that I focus most on, particularly in the pediatric population, is cord relaxation. So I don't tend to do a lot of the ponte osteotomies or the kind of the smaller osteotomies. First, a lot of the angular deformity, I really focus on the three-dimensional, the three-column osteotomies just for relaxation because of the concern for cord changes. A lot of the times, some of the AIS population is quite flexible, and so the facet joints move quite a bit. So I really don't do anything. Maybe I'd take a little bit of the inferior facet, but I really don't do a whole lot except for the angular deformities because the power of the instrumentation of the implants is pretty robust. This is a patient that came to us, unfortunately had some neurologic changes during their index procedure and kind of came to our institution after having kind of fractured their implants down here and then had another fracture to their implants a little bit lower. They had a congenital pathology and unfortunately their spinal cord was draped over that pathology, and so I suspect that the reason why during their index surgery they ran into some difficulty and some trouble is because of the cord compression. So typically with a three-column osteotomy, you're able to get some improvement to really shorten the cord, though the degree of essentially the angular deformity is quite high and quite likely to cause a neurologic change. You can really get a nice correction with the three-column osteotomy. So I think it's actually quite safe. And it's one of the safest things to do for these patients with angular deformities. It cannot be understated enough. So we can follow patients over time. They can start when they're 2 and 3, and you can follow them until unfortunately their deformity gets quite robust and quite big, but we know that we can address and use a three-column osteotomy to allow for their overall improvement and through a very, very safe operation. These are just some of the similar examples of utilizing the three-column osteotomy, which is not a newer technology, but one of the very fundamental pieces to make sure that a lot of times these patients are addressed and are safe with correcting their pathology. Then I want to highlight some of our failures. So there are patients in which we do see and we evaluate in the office and clinic that we think that we can hit home runs and do very significant improvements. So we can place them in halo gravity traction. We can try to stretch them. We can think of all sorts of strategies to improve their quality of life. But when we're in the operating room and their bone feels like it's osteoporotic and things just don't move, and this is the best that we could get. This is unfortunately just the best that we can get. And so I show this is to show that not all of our cases that we perform and we operate on are home runs, but certainly we have to sometimes just get what the table gives us, and then we allow for some improvement in their overall lung capacity. Whether this is a benefit or not, I'm not really sure, but that being said, we gave them an effort, and this is where we came to. So. And then we can follow things up with essentially very rigid deformities, and we can get some successes when we do the three-column osteotomy as described. And so with that, I want to thank everybody. So when I think about incorporating newer technologies, we look to the literature and then see what techniques are available to us. We try to incorporate some of those newer techniques and thinking about and the concepts of patient safety, try to minimize the inefficiency, because as we're starting to incorporate some of these newer technologies, it does increase and change our workflow. And so how we can incorporate them into a more robust workflow and try to think a little bit outside the box so that we can overall have an improvement in the quality of life of these patients, and we can make improvements in our ability to treat these pathologies. So I want to thank you.
Medical honor.
Nice talk. How do you see mixed reality or augmented reality playing out in the future? Do you think it will advance to become a standard part of our armamentarium?
Yeah, I hope, quite frankly, I hope it actually really piggybacks onto our utilization of intraoperative navigation, where instead of having a display that is registered, there is the display, instead of a two-dimensional platform, is a three-dimensional platform, and it can be overlaid on the patient. More so, you looking at a screen, you can actually look at the patient and have that representation being there. So I really think that it's part of the natural integration of how intraoperative navigation is going to play out, and I hopefully with the ability to register and then have that three-dimensional representation on the patient, I think is ultimately the next step. So I do think it's well within our future. Yeah.
question for you, Jamal. You mentioned that you don't do many type 2 osteotomies, so Smith Peak or Ponte osteotomies, but you still seem to get great derotation, great coronal correction, and induction of kyphosis. What do you think? How does that work? Like most of us struggle with that without the type 2 osteotomies.
I've started just to utilize the fixed angled screws, and by utilizing them and then the rod roll, I found it kind of saved a little bit of time and allowing for the correction, and using a very stiff rod. The screws are quite robust, and particularly if you have a good screw bone interface with, and a lot of these AIS patients do, you're able to actually get pretty good movement of the spine. I do always go back to, are some of the stiffer curves, can we use the anterior releases at the same time we maybe give halo traction? Could that, obviate the need for any of the type 2 releases? I don't know, but, perhaps maybe that's something that I'll explore, but I don't know, I've had good success, particularly if you see a lot of movement at the level of the facet joint after you place the implants and you kind of just wiggle and move them. It just seems like with the fixed screws, you can get a lot of play and a lot of derotation ability with them. It's a little bit more painful to actually place the rod in, but it is pretty powerful though.